America's healthcare system is almost unanimously viewed as being unaffordable, dysfunctional, and severely in need of transformation. APG President and CEO Don Crane talks with leading healthcare executives, physicians, and other visionaries to explore solutions to lower costs and improving quality of care by accelerating the movement toward value-based care models and away from fee-for-service. Want to be inspired by our nation's foremost thought leaders in healthcare? Then this show is for you. Here's your host, Don Crane.
I had a chance to talk the other day with Michael Chernew, who, simply put, is one of the most influential individuals in American healthcare today. Dr. Chernew is a professor of healthcare policy within the Harvard Medical School and is the current chair of MEDPAC, the Medicare Payment Advisory Commission. As listeners know, MEDPAC is a federal agency that provides nonpartisan advice to Congress. It just released a 500-page report to Congress, which contains, among other things, many suggestions on how the Center for Medicare and Medicaid Innovation should overhaul the many alternative payment model pilots. The inspiration for the podcast, however, was an article Professor Chernew authored that appeared in JAMA on May 6th, the title of which was A Path Forward for Alternative Payment, Build a Portfolio, Not a Garden, in which he offers his opinion that CMMI should trim the number of APM pilots to create a more harmonious and less conflicting collection of programs. But what really caught my eye was Professor Chernew's very cogent summation of a primary goal of APMs, that is, to treat avoidable waste in healthcare as an asset that can attract innovation and be harvested to produce value, and yes, profit. This is bedrock APG philosophy, and it was sure nice to hear it described to perfection by the chair of MEDPAC. In the podcast, Dr. Chernew explains this asset concept and many other points about the value movement that I think are important. I think you're going to like it. Take a listen. Professor Chernew, so good to have you with us this morning. Thank you for joining us in this APG podcast. How are you today?
I'm great. Thank you so much for having me.
Very, very, very good. If I may also, Professor, since we prepped and talked and I think we're friendly, may I call you Michael? Is that okay?
You can call me Michael. You can call me Mike. You can call me Betty.
Okay.
Whatever.
Very, 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 very good. Well, I want to obviously, reflect the kind of respect I have for you. You're the professor of healthcare policy at Harvard Medical School. You're the chair of MEDPAC, the Medicare Payment Advisory Commission. You were the vice chair in that commission from 2012 to 2014 and a member before that, 2008 to 2012. You're a member of the Congressional Budget Office's panel of health advisor, co-editor of the American Journal of Managed Care, and on and on and on. I can hardly imagine a more whatever powerful CV set of experience for our conversation today. So I'm really pleased to have you with us. So with that, let me dive into it if I may. I think probably makes sense, Mike, to go ahead and have you say a word or two about MEDPAC and who it is, what it does, and then also this distinction today about, when you're speaking on behalf of yourself versus when you're voicing, a position of MEDPAC, so that the audience is clear on that. May I have you do that?
Sure. MEDPAC is an independent congressional agency that advises Congress on Medicare payment policy. We're required to put out 2 reports a year recommending to Congress things like the update factors for the different fee schedules. We address a whole series of other issues related to Medicare policy. The commissioners, myself included, are appointed by the GAO. There's 16 plus me. They're experts in a whole range of areas. There's many that are representatives of different industry segments. So we have people, for example, representatives is too strong a word. People come with their perspective from different industry areas. So we have people who work for large hospital systems, people that sort of are prominent in the physician community, primary care docs, specialist docs, academics, people that are expert in public policy, things like that. So, I don't know how many independent congressional agencies there are like MedPAC, but
Right.
we report to Congress, and we do so sort of without any partisan angle.
Any comments about sort of your whatever representation here during the podcast today? When we think you're here, we're
Yeah,
listening to you individually versus MedPAC.
absolutely. So I think the easiest thing to say is you should take everything I say is an opinion of Michael Chernew, the professor, not an opinion of MedPAC, although I think you'll ask me questions about MedPAC and I will comment about my views on that. But again, MedPAC is a commission, and the opinions of MedPAC are reflective of the opinions of the commissioners writ large. When we make recommendations, we vote on them. Um, so I don't speak for all the commissioners per se, although I can certainly reflect where I think the consensus of the commission is.
Very good. Perfect ground rules. So let me dive into it. So, would have wanted to speak with you under any and all circumstances, but what really prompted this was an article you wrote recently dated May 6th, 2021, that appeared in JAMA entitled A Path Forward for Alternative Payment, Build a Portfolio, Not a Garden. And that, of course, article says an awful lot of things, but I want to start with the assertion in it that waste in the basically delivery of care is an asset for harvesting by all of the APMs. Can you explain what you mean by waste as being an asset?
Yeah, so I think we would agree. I hope your listeners would agree that there's a lot of inefficiency in the American healthcare system. There's a lot of ways you can define that inefficiency, but in my case, what I mean mostly is people are getting healthcare services that they perhaps shouldn't get. Think, for example, about choosing wisely, or they're getting services from sites of care that perhaps they didn't need. So they're getting care in some more intensive post acute care settings as opposed to less intensive post acute care settings, things like that. And I spend a lot of time worrying about the quality of care and the access to care that people in the US get, particularly, obviously, Medicare beneficiaries, as my role as MedPAC chair. Uh, but within that context, it's important to understand that the country faces really important fiscal challenges. And to address those fiscal challenges, one strategy is to change the way that the providers, hospitals, physicians, nurse practitioners, skilled nursing facilities, all the different types of providers are paid. And the essence of those changes is to make payment broader so that the payment aren't as fragmented for particular DRGs or RVUs or whatever they happen to be, but instead they span time and they span providers. And in doing so, those broader payment models, those more flexible payment models, allow the provider system writ large to share in some of the savings when those inefficiencies are eliminated. So if you can avoid an MRI that wasn't needed, if you can avoid some testing preoperatively that wasn't needed, if you can send somebody to a lower cost post-acute setting, for example, all the associated savings gets shared with the delivery system. The challenge in all of these models is to define who in the delivery system gets to keep that share of the savings. The models are broad, so they span providers and time. And as a result, if a post acute care visit is avoided, or the setting is shifted, or an MRI is avoided, who should reap the savings associated with that? And so there's a lot of organizations, some of which are provider systems, some of which are non-provider organizations that work with provider systems, are building business models around both generating the efficiencies that we want and then keeping a share of the savings. So in order to be successful, you need, as an organization, to essentially own that waste, because if you own that waste, you can then get paid to eliminate it.
Yes.
If you eliminate waste that is owned by someone else, that other organization keeps the savings. So last point I'll make, and then I'll stop talking. In the existing system without alternative payment models, if waste gets eliminated, it is effectively owned exclusively by the payer. So in the fee-for-service model, if a wasteful MRI or a low-value MRI is not delivered, that simply lowers Medicare spending, and the savings are captured by the Medicare program, and the delivery system doesn't capture any of that. The beneficiary captures some because they don't pay a copay or whatever. But for the most part, it's the payer part is captured by the program. These new payment models take some of that ownership of that waste, if you will, and give it to the delivery system. So if they can eliminate it, they then can keep some of the savings.
Well, very good music to my ears. No surprise to you to hear this, because this is bedrock APG philosophy, and I have spent now the better part of a career trying to explain, perhaps less effectively than you just did, really the underlying basis for moving from fee for service to capitation. Um, Capitation presents this opportunity to remove waste, which I think many, for a while there, I think it was almost a consensus view that some 35% of the spend in the healthcare system is on avoidable care, aka waste, and that can be translated basically into profit, and thus it's a better model. And so anyway, that's been my mantra, and so happy to hear you, I think, confirm that. I feel better already. Michael,
Wonderful.
very good.
It's always good to start out. It's always good to start out in agreement, and the fact that we agreed on is remarkably soothing to me. I really appreciate it.
Ditto here. So next point in this interesting JAMA article is about moving from the let 1,000 flowers bloom approach to a portfolio model. So now we're referring to the CMMI, the Centers for Medicare and Medicaid Innovation, I think is the title, and its charge in the Affordable Care Act to test models to help the system move from volume to value. And so you have posited that we should get out of the gardening a little bit and move into something a little more, I'll just use the word intelligence. So can you explain what you're talking about there?
Yeah, although I'm not sure I would have used the word intelligent, but that's fine. So when we started to think about collectively transforming the payment models in this country, it was not clear the right direction to go in. Places like California, and for that matter, Massachusetts, have a delivery system structured in particular ways. For example, here in Boston, we have a lot of large delivery systems, some excellent delivery systems. They're quite comprehensive in the care they deliver and the components of care that they control. And other parts of the country, not so much. So the original paradigm in moving towards alternative payment models was, I think, this let 1,000 flowers bloom model in which there was a lot of experimentation. And I think part of the bedrock of CMMI involves some of this testing and experimentation and diffusion, which by and large, I'm supportive of, and I'm certainly understanding of how it started that way. The problem arises that as models change, as there's different rules about when they can be recertified and diffused, as they begin to bump into each other, they begin to work at cross purposes, because you can have groups that are participating in a population-based payment model in which the accountability is assigned to one organization, and then the patients that are part of that may get a particular service that triggers an episode of care, in which case the accountability of the episode is given to someone else, and you need a series of complicated rules. And as you launch new payment models, you can siphon away the responsibility, say, from the population-based payment model in different ways. There might be similar models that for example, the Affordable Care Act initiated a population-based payment model called the Medicare Shared Savings Program, MSSP. That's actually outside of the CMMI models, but there's similarities between parts of the MSSP program and some of the population-based payment ACO models that CMMI was running. And so there are questions about, should you be a next gen? Could you be a direct contracting model? A bunch of things like that. How does the episode model for joints, CJR, interface with the episode models more broadly, BPCIA, bundle payment for care improvement advanced model, and CMS and CMMI more specifically have developed a whole series of rules about how these things work. They're actually quite complicated, but more importantly than that, it's a conceptual problem when you are launching models and running them independently and not acknowledging that they all interact together. So I like the portfolio analogy because it makes me think when you buy a stock, you don't just think about the performance of that stock, you think how it affects the sort of risk and return profile of your entire portfolio. So you might want some stocks, some bonds, some, you're building a bunch of different things in your portfolio that will work well together to give you sort of the risk return trade-off you would want. That's why I like the term portfolio. My friend and colleague Mark Fendrick, whose son is a tremendous bassoonist, thinks a lot about orchestras. He prefers an orchestra model where we think of all these different components of being able to play well together. So maybe people can write in whether they prefer orchestra or portfolio. Please say portfolio, because otherwise I will have to change my article, which is already in print. But nevertheless, the theory is the same.
Sure.
That we want to think about we're now at a stage where I think we need to think about a vision for how payment should work in this country. And while some testing is certainly still needed in a variety of ways, and there's always going to be opportunities to change the model, so I don't in any way mean that we should lock payment in stone. I think that as we begin to develop and launch new models, we have to pay attention to how all of those models work together to give us the healthcare system we want and the healthcare payment system that we want, as opposed to thinking about a bunch of one-off things. The last point I'll make in this context is, if you think about how we deal with drugs and drug testing, is we test drugs often against placebo. So if you found that the J&J vaccine works against placebo and the Pfizer vaccine works against placebo and the Moderna vaccine works against placebo, you would never give somebody all three vaccines. You would acknowledge that they have to, you have to think about how they interact and how they work together. And there's an analogy to payment that even if you find that this works against fee for service, that works against fee for service, the other thing works against fee for service. If you adopted all three of them, that doesn't mean they are all going to work the same way, or that the collective thing would be the sum of the results from any of the three evaluations.
Got it. You mentioned testing. So the CMMI, that's their charge, test. They've been doing it now for many years. The Affordable Care Act was enacted in 2010, and they started their testing not too long thereafter. Do you have a vision, or MEDPAC for that matter, as to sort of when testing either ends or and implementation begins, whether that's graduated, overlapping? Or when do we move out of testing and start to move into implementation?
Yeah. So first of all, I'll be explicitly clear here. MEDPAC does not have a view now on that per se. So I'm talking as Michael, not as MEDPAC.
Okay.
My personal view is testing is never going to end per se. There's, you realize you're talking to an academic. My actual day job is evaluation in a whole range of ways, and I think that there's going to be continual system and process of evaluation, and CMMI, both through statute and otherwise, does continual testing. I think the core question is, what are they implementing and what are they testing, and when are things part of the sort of natural background landscape versus when are they an experiment? And I do think that there's some semantic issues. I'll pick one which is really illustrative. I'm going to use some words, but I don't mean them quite literally. There are several versions of what I would call high-powered population-based payment models. Think NextGen or Direct Contracting Global, just to pick two.
Right. Okay.
There's a bunch of parameter issues with each of those. How are benchmarks set? How's risk adjustment done? How's attribution working? A bunch of things like that. There will be continued learning as those things develop. I think having a somewhat stable vision that a high-powered population-based payment model track exists is an important direction to go in. The actual details of that, I think, can change over time as we learn more. The same is true, just again to pick an analogy, we implemented in the early 90s the DRG system. which essentially changed the premise of how we paid hospitals towards this prospective payment system, which
Right.
in some ways was the first bundle, although it didn't span providers in quite the same way as these new alternative payment models do. But nevertheless, the DRG system has evolved and continues to evolve over time. We have MSDRGs. We have a bunch of other changes in what the actual rates are.
Right.
There's a series of other processes that are overlaid on top of the hospital payment system that relates to DRGs. So there is this continual evolution of payment that I think is a good thing, and there's a continuing evaluation of it. The same is true with how we pay for quality. We have the hospital readmissions program. We have a bunch of other value-based payment models. We try and bring them together. MEDPAC has a bunch of recommendations about how to do value payment models. So there's always going to be these changes. These changes are always going to be evaluated, and I think that's important. The core point is to understand that these basic payment models are going to be moving forward, and we want to maintain that direction. And I mean, it's possible we get to a point where say, this entire direction was wrong. We need to completely uh, change course. But my read of the evidence now is that these alternative payment models, by and large, are a small win. And I think they can be made a bigger
Mm-hmm.
win, but at least for now, they are a small win. They serve a lot of purposes beyond just the fiscal. I believe there's small fiscal savings. I think they serve broader purposes as we think about things like telehealth. Putting telehealth into a fee-for-service environment is a nightmare.
Yeah.
Um, so I think you get a lot of opportunities to build out these models, and we will continue to do that on an ongoing basis.
Very, very, very good. Well, I think that in listening closely to recent comments of Liz Fowler, the new head of CMMI, as you know, I think that they're either agreeing with you or doing what you say in part, certainly because she's talking about fewer models. I don't know if she uses the word portfolio versus garden or orchestra, but nonetheless, fewer models. The other point that they seem to be making is to convert some of them from optional to mandatory. You have a perspective on that?
Yeah, so first of all, I think CMMI and Liz are doing an absolutely outstanding job in a whole variety of ways. This is obviously a very complex area. I do agree with you, and again, I have no particular insight that they are trying to move to the what I would consider to be the next phase of APMs, where they're thinking about how it all fits together and how you build a delivery system that works for the beneficiaries. But in order to work for the beneficiaries, it has to work for the providers. And I really think there's a lot of really good work now being done at CMI and CMS more generally, for that matter. The issue of voluntary versus mandatory is a complex one. I tend to think of it as a little bit more of a spectrum. So, for example, there are people who believe in mandatory models, but I think there are providers that would not be well suited in certain types of mandatory models. There's only so much risk, for example, you can put on a provider system. And when you have providers that are smaller, they may not have the capacity to bear that risk. So you need to think through the heterogeneity of the provider system and how you're designing the tracks, and recognize because of that heterogeneity, it's very hard to force an organization into one track or another, particularly as the tracks become more high powered. But I do think that you can encourage participation in a range of ways. I should point out that the existing fee schedules in Medicare, the current law baselines, I guess I'll pick the physician one because this is APG, is
Right,
we had a system called the sustainable growth rate. It
right,
was many things, it was not sustainable. Um, we moved to a system that's basically the macro MIP system, and the win in that situation was to avoid the scheduled fee cuts, but to move to a system of baseline fee updates that are really, really, really flat. And in nominal terms, if you follow current law baseline, you would see a reduction in the inflation adjusted fees that providers are getting. On the facility side, there's in the Affordable Care Act productivity adjustments, which essentially deduct from the updates that facilities get a factor related to productivity in the country, which means that providers are getting fee updates below what their input costs are rising as. And in fact, if you look going forward, the inflation adjusted collective price increases in Medicare are forecasted to be slightly negative um, uh, over the next, roughly 5 to 10 years. So the core activity going on here is to allow institutions and providers to harvest some of the savings from removed inefficiency so that they can effectively survive financially with lower underlying fee updates because they can capture some other profits by doing less things. That is an incentive
Yeah.
for going forward. It doesn't make things mandatory. It allows providers to make a calculation in which they want to own the waste so that they can do better than if they're just in a fee for service system that pays them for everything they do. And so you certainly can make that stronger. There's issues. I don't have a strong opinion, but there's issues about, for example, the APM bonus, which is scheduled to go away.
Right.
Um, and how you set up these things. I think it's incumbent, and I know CMMI and CMS are thinking about this, it's incumbent to build models that are attractive. The advantage of making it more mandatory or having stronger incentives is it allows you more flexibility in how you design it. They don't have to be quite as favorable to providers, and it avoids a complicated actuarial problem, which is, for example, if you set a regional benchmark, and there's part of a regional benchmark in some of these models, and the participants are all people and organizations that were having spending below the region beforehand, you will end up losing money because of the selection who's participating. And
Right.
so getting more people to participate, particularly for that matter, the high spending groups, is unbelievably important. I think mandatory might be a little strong, but we are going to have to think about which models can be designed in a way to really encourage participation. And in some cases, particularly CJR, where you can have some things that are mandatory because they're a little bit narrower. And so this is going to have to be an ongoing discussion. Mandatory is a good thing in many ways, but it does have drawbacks that have to be balanced. And so we're going to have to be a little nuanced in where we are on that spectrum.
Very good. So let me turn to one of the CMMI programs pilots, near and dear to APG's heart. This is the direct contracting program involving both global and professional risk. So we asked for that, got it, and now it's been shelved for some period of time as Liz Fowler and her team reassess all the models, which we would fully expect a new administration to do. But it's got us very nervous because we see those two models, and I'm not talking about the geographic, which was indeed halted, and that's probably okay from our perspective, but the two direct contracted models, the professional risk and the global risk, we see as sort of the logical next step in the evolution of risk taking from groups. So they start with upside only and Medicare, and MSSP, ACOs, et cetera, et cetera. And these models now shelved represent the next step, evolutionary step, and get very close to our view of the destination, frankly, that we should all be headed to. So we're, highly nervous and concerned as to the future of that model. Do you have a perspective on that yourself?
So I can't look. I've already said I can't speak, or I'm not going to speak for MedPAC per se.
Right,
By the way, MedPAC doesn't have a particular view on that.
right,
I certainly can't speak for CMMI. My overall view, and actually my expectation, is that there remains a lot of enthusiasm for alternative payment models. There remains a lot of enthusiasm for models that have some of the features of, say, the direct contracting global model. And by that, what I mean explicitly, it's population based. It is working through the provider system as opposed to, say, the health plan. So, for example, the Medicare Advantage program is population based, but it's working broadly through plans. I think there is enthusiasm for this sort of what I called before a high-powered population-based model. I suspect as the world moves forward, you will see something like that. I understand there is a lot of tension in basically the transition period. I think it is important that I know they are thinking hard at CMS about this transition period. On one hand, you don't want to leave big gaps over time as you build what you say may ideally want to build. On the other hand, you don't want to build something that eventually you're then just going to change completely. So my view is there should be and will be a high powered population based payment model moving forward. And that I guess I would urge patience as this all comes to fruition. But I think there remains, I'll speak for me personally, I
Hmm.
believe I'm enthusiastic about such a type of model. And I believe that others that are much more important than I share that view. And so I think it's just a matter of working out the kinks and how this thing goes. I mean, one of the problems in anything I wrote, moving from a let many flowers bloom to a portfolio model, in any of those types of transitions, the actual movement is challenging and it's complicated by some of the other rules around how these models become recertified and how they're implemented and how they're evaluated and what the comparison groups are. So the institutional aspects of this and success are non-trivial, but I think the intent is probably uh, one that I think you would be supportive of. There are, of course, other types of models as well, but I certainly think you will see these types of high-powered population-based models going forward. I certainly hope you will.
I think you're right, and I agree with you. I'm not much of a mind reader, certainly have high deal of respect for Liz Fowler. But I do know that some of the opponents now, or the critics of the direct contracting model, urging that it be restructured entirely, are arguing that some of the applicants or participants are health plans, and that health plans are sort of infiltrating the program and thus traditional Medicare, and will bring with them their business model of upcoding and risk adjustment. So they see, I think maybe the whatever pollution of a traditional Medicare with health plans with a Medicare Advantage upcoding bent. Now I don't know if I've exactly captured their criticisms, but I think I have it pretty much right. Do you share those criticisms, or do you have that view?
I don't have that view. I understand the criticism. I think there is a tension in who runs these models and what this actually means. I think and again, Don, I'd love your view on this. I think there's a big distinction between direct contracting global and direct contracting geo in the following sense. My understanding, and again, please correct me if I'm wrong, is direct contracting global fundamentally requires people be attributed to the model through the providers that are participating in it. So you are not attributed, for example, to a health plan and then split across the primary care providers that you may go to. Instead, it's a model that's probably closer to some of the other companies, up Gallaudet as an example, that are working with and signing up and partnering with provider groups, but at the core, the control remains the attribution is working through the provider groups and they're picking how it is working as opposed to having the provider groups disintermediated by the plans, if you will. So before I say more about that, I think this is the opportunity for you to correct me if I've misinterpreted the rules around direct contracting global.
No, I think you're about 90% correct. The one edit is the inattribution, I think, on the direct contracting model. There's both attribution, complicated subject, but there's also voluntary alignment. So there's an allowance for Medicare beneficiaries to voluntarily sign up, as it were. So there's both forms of alignment, I think. So I think that's about the only edit I would make. But you've invited my views, and so I'll share them with you. So first, just to be clear, there once upon a time there was the geographic model, not to be confused with the global model, and geographic really did seem to have it as its purpose to invite real technology companies and who knows what really historically non-players in the healthcare system to come in, and indeed that's been scuttled and I think entirely, and so not referring to that right now. when we look at professional risk and global risk, I think back actually to our initial promotion of global capitation in these models. We proposed it maybe 6 years ago. We called it the third option. But in that paper, we saw a role for health plans, but not as prime contractors, but as subcontractors, something akin to ASOs in the self-insured model or akin to TPAs, on the theory that there's a lot of work to do. It needs to be physician group centric as a prime contractor, but one that we're probably need management and consulting services from a variety of contractors working with it, as we see across the landscape now, particularly in self-insured models, which is really, these direct contractor models are very like that. So we always envisioned it as being a physician group model, but we thought there might be a role for health plans. We never really thought health plans as prime contractor. I think the only other thing I'd say before I'd ask your opinion is, I don't know, 80% of the healthcare system is sort of quote unquote, within the franchise of health plans now. When you think of MA, when you think of commercial, when you think of Medicaid, is now Medicaid managed care through health plans, I think across 80% of Medicaid. So, health plans have a huge role in the American healthcare system, for good or bad, and I'm not arguing right now. They bring capital, they bring experience. I think actually they probably should have not a prime contractor role, but an ancillary role to support what goes on in traditional Medicare. That's my kind of personal view. But that's the debate and the tension right now. Some think that health plans are completely, persona non grata and should be out of this program entirely. And I don't agree with that. So what do you think?
Well, so first of all, I think, of course, health plans increasingly own, for example, physician practices. So the boundary between a health plan and a physician practice can be blurred. Obviously, you're from California, you understand Kaiser, so we could have a longer conversation about that.
For sure.
I think, and I think whatever ills you think there are in health plans, it doesn't take you far to find issues going on in provider groups, that where they do a lot of the coding and a whole series of other things that are going on. So I won't
Agreed.
go through some of the other issues there. I think the question about who should be subcontracting to who is a little bit besides the point. There's actually some economic theories that it doesn't matter as long as the contract works well.
Right.
While it's true that health plans play a large role, obviously, in the American healthcare system, understand that the core of the American healthcare system is the providers. Like, what we care about is people actually getting care. The
Yep.
financing matters. I'm an economist. Boy, I think the financing matters. I think the financing sets the environment in which care is delivered. But the value add in the American healthcare system fundamentally is value added by providers. Like, that's what you need. People get sick, they want to get better. Health plans can set the environment, but the actual people that are getting them better are the physicians, the hospitals, and the whole slew of other people that are making medical services, drugs that they take that helps them get better. And I could see a world in which the contracting works through the providers and they contract out separately to the, say, health plans. It doesn't have to be health plans, by the way. There could be a lot of organizations that are sort of information technology, other types of organizations that are risk bearing that might not actually be a plan the way you typically think of as a plan organizations. And again, I don't know, I won't speak. I pick Ality and I can pronounce them, but there's Evolent, there's Caravan, there's a bunch of these types of organizations. Or it could be a situation in which those other organizations fundamentally get the contract, but the only membership they get requires them to contract with the delivery system, which gives the delivery system some control about things like how risk is shared and what the terms are. And so I could see this working in a bunch of different ways. Some organizations have more capabilities. They want to do a lot more in-house, so they don't really need to work with other organizations. And other providers really are not wanting to spend a lot of time building the data analytics, the communication skills, the interaction with beneficiaries, all the other things they do. And they want to find support from organizations that might help them, say, implement an EMR that supports their goals to one that actually helps them bear risk and do other data analytics to find where the waste is. We talked about waste before. I didn't mean to be glib, but it's easy to say as an academic. I think it's important to understand that there's a lot of nuance in high versus low value care. One reason why I like these models, it gives a lot of discretion and autonomy to the delivery system to decide what is needed and what is not within the sort of paradigm of accountability, as opposed to a much more prescribed version of do this in this case, don't do this in that case. But I don't have a strong view about whether or not you should have the fundamental contractor be the provider subcontracting out to plans or other organizations, or whether you should allow the other organizations to be the fundamental contractor who then is partnering with the underlying delivery system. What is clear is no organization, no plan organization, no IT organization, no one can survive in this unless you have the providers actually delivering care. Like, that's the product. And so the providers at their core will need to be on board with how this works, because if the provider system isn't working, if the care delivery system isn't working, there's nothing that you can accomplish.
Agreed completely.
You're listening to APG on American Healthcare. We'll be right back after this message.
I want to thank the TDC Group, the exclusive sponsor of the APG on American Healthcare podcast. The TDC Group is the nation's largest physician-owned provider of insurance, risk management, and healthcare practice improvement solutions. Visit tdcgroup.com to learn more.
We're back with more from APG on American Healthcare. Once again, here's your host, APG President and CEO, Don Crane.
Let me shift our focus to MA, obviously a Medicare program, so thus of interest to MEDPAC. And I'll ask you to react basically to my thinking or observation here, a good way to approach it. So as we look at the LAN reports and we try and evaluate the extent that value-based contracting and the like is penetrating various programs, you take a look at Medicare Advantage, and I think the LAN schema has sort of four categories, and the most sort of whatever evolved of them is a population-based payment. And there, as you look at Medicare Advantage and ask the question, how much has value kind of penetrated Medicare Advantage? I don't recall the precise percentage, but it struck me as small, something on the order of 15%, I think, of payments in Medicare Advantage are, according to whatever the definition used by the LAN and the health plans that supply the data, value-based. I then further subtract from that percentage California, where the capitated integrated model is almost exclusively used in Medicare Advantage. And so just for analytical purposes, I sort of subtract out California, and it leaves me with the observation, maybe correct, maybe not, that quote unquote value has not penetrated deeply into Medicare Advantage yet. What is your thinking on that?
Medicare Advantage plans are very heterogeneous. They do a range of things to support value. It may not be exclusively in payment, although I haven't looked at the numbers, so I can't comment on your sense of sort of value-based payment. They have a series of other tools. They can use benefit design. What does seem to be clear in the engagement with the health plans that I am familiar with, the Medicare Advantage plans, is they very much are engaged with their providers. Often, I think it's in what we would call in spirit of partnership. There are examples of Medicare Advantage that I think would pit the plan against the providers and how they do prior auth, for example, and a bunch of things like that. Right. So there is a vision, it's not crazy, that the plan taking population-based responsibility enables them to engage the provider system and essentially procure the delivery system services they need in a way to promote value, and it may involve changing the incentives that the provider gets. It may involve a series of other activities to manage utilization. And I think the MA plans have a wide array of what they're doing. I will tell you now, this is a self-selected comment. Many
Hmm.
of the plans that reach out to me about what they're doing in MA, or for that matter in commercial, are plans that are doing alternative payment models. You should know my start in this area was with Blue Cross Blue Shield of Massachusetts and the alternative quality contract that
Hmm.
they implemented. And I actually think the private sector has been out in front of where government has been in terms of developing these models. It's not clear that MA plans are always using them, but I know Humana, I know Anthem, um, I know Aetna, I'm sure a ton of others, United, has a series of these types of value-based payment models that they're experimenting with and putting in place. And in many cases, they're building much closer partnerships, and obviously in the case of United, ownership um, of the parts of the delivery system, which is a separate topic. But this type of financing integration with care delivery is an interesting mechanism, which you know through Kaiser is not new, right?
Yeah, absolutely. Well, so, and there indeed, these MA plans and other plans have an array of tools to promote sort of managed care and better integration and value and the kind of things we want. But if they are not paying some budget-based payment downstream and continue to cling to a kind of a fee-for-service payment model, are they really moving the needle for us, and are they achieving the value that we envision? In other words, it's moving away from fee for service, an indispensable element of value.
Yeah. So my quick answer to that is no, it is not indispensable. You can
Mhm.
look at a lot of other countries that pay varying versions of fee for service. Um, and I think you can make fee for service systems work with the right infrastructure around it. So, um, again, for the Medicare Advantage plans to work, they need to have a bunch of providers participating with them in a range of ways. And that limits to what they can do. There are issues broadly about what I would call market power. And, we have to think a lot about competition policy writ large.
Yeah.
But for the most part, I think ignoring some issues about how we pay Medicare Advantage plans, which rely on, there's some concerns about how markets are defined. There's concerns about coding. You mentioned there's concerns about the Quality Stars program in Medicare Advantage. There will be a chapter in the MedPAC report coming out shortly on this. Um, but I think at its core, the evidence is pretty clear that Medicare Advantage can provide value in terms of utilization in a whole range of ways, and they can engage the delivery system to get rid of waste in a whole range of ways. And what the problem now with Medicare Advantage is writ large how they're paid. But I think we can make some relatively modest changes. Hope people like the MedPAC report on this. I think we can make some relatively modest changes to the program to help us share in some of the savings that the Medicare Advantage plans are generating. They have the advantage, I might add, um, of being able to engage with the delivery system in a way that isn't impeded by some of the underlying cultural issues that occur within the delivery system. So, for example,
Hmm.
we talk about APMs. Physician-led APMs, ACOs in particular, have performed better, much better than hospital-led ACOs. We could debate as to why, we can debate the analysis, but I believe
Hmm.
that basic conclusion is true. I believe part of the reason why that conclusion is true is if your goal is to keep people out of the hospital, that's harder to do if you're a hospital. Um, and I think there's a lot of hospital systems and that can do a lot of things. I believe we can change the models in ways that support their success, but um, the health plans can go after those things with their data analytics and other tools in
Hmm.
ways that are sometimes difficult for the medical community to do. Um,
Hmm.
so I guess I have one last point on that, which is one of the things that has been most exciting for me in the past decade, in many ways, has been the uh, Choosing Wisely initiative from the American Board of Internal Medicine Foundation. I suspect many listeners are familiar with it. I assume you are, Don.
Yes, I
Um,
am.
and um, they identified a lot of low value care, and this came from the medical specialty societies. This was not imposed upon them
Yeah.
from an outside organization.
Hmm.
And they published, I don't know, 400 plus or so of these things. If you look at the utilization trends of these things pre-post, you find stunning little movement. There are pockets, there are
Yeah.
pockets, there are pockets of success. So I don't want to deny that there are, and there's organizations working at this, but it is simply not the case that labeling and identifying sort of waste and associated practice patterns makes the medical community just melt it away.
Right.
Um, and because of that, I think there really is a role for a broader change to both payment. We've done some work in Medicare that shows under these other payment models, low value care drops more than otherwise. So I think there's a role for payment. Payment is certainly not sufficient.
Right.
It really takes a lot of hard work. We've been working with Beth Bortz in Virginia. She's working with a lot of delivery systems about low value care and how to get rid of it. And there is a role for plans and other entities to help do it, because while it is nice to believe that the medical community, once sort of it's published, will change their practice and practice efficiently, I think the decades of geographic variation work and the experience I've seen with Choosing Wisely says we certainly need physicians and hospitals and all the other nurse practitioners and providers that matter in the system. But without some sort of broader management limits and engagement and initiatives, you simply won't see efficiency take hold miraculously.
Well, completely agree. I mean, you're talking to somebody in Don Crane here that believes firmly in that, the expression money talks. Well, payment models talk, and not while not alone sufficient, utterly necessary in terms of moving to value. So, I mean, certainly my view. Hey, let me throw on my California hat for a minute, which I seldom do these days. I have more members outside of California than inside California now. But as I look at CMMI and Brad Smith's now almost famous article, I think in the New England Journal of Medicine, that basically concluded that of the 54 of the CMMI pilots and demos, only 49 delivered a net savings to CMS. I think that
I
was
think you mean that
probably.
in reverse. 49, it's not the out of 50, it was not 49 delivered savings.
Oh, did not. That's what I
That's
do
right,
mean. But
exactly.
anyway, and I
Yes.
won't use the word they were all failures because, as you pointed out earlier, it ain't just savings by which we measure, improvement in value and so on. But it was stunning to see 49 of 54 not deliver savings, which is something that I think we all expected from these alternative payment models, affordability being such an important point. So looking at that kind of experience, shifting my gaze now to California, where I think I have about 185 members. I don't know their individual financial circumstances, but we haven't had any insolvencies for a long time, and so I have a strong feeling that they're doing very well and have done so for a long time. And so I compare, you know, difficulty with the CMMI models, success with the California models, plural, because there's a plurality of different ones in California. And I have a hard time reconciling the two. And so I ask you to help me. What's going on here? I mean, why is California so successful, and why are the APM models and pilots and so forth not? And should we be looking at that?
Well, um, let me start with your original scorecard approach. I don't think the scorecarding of 54 and X saved, X percent saved uh, should be used to generalize across APMs writ large. I think, for
I agree.
example, if you look at those models, that overwhelmingly the population based models saved money. They certainly changed behavior generally. In some cases, because of the amount of savings that was shared, the benchmarking, and a bunch of other things, the selection, they may not have saved money for Medicare per se. There's some issues related to what the comparison groups are. But I think by and large, the evidence on population based payment models are that they, A, change behavior, and B, say the case of MSSP, but I think others, Pioneer, for example, um, clearly saved a little bit of money net for the Medicare program. And just by the way, if you look at Medicare Advantage and you gave it the same criteria, you would think Medicare Advantage is a failure because it hasn't saved money net for the Medicare program. But in fact, I think the Medicare Advantage program is a quite big success. It's just the payment isn't working well. And I think there's some analogies. The point is that
Hmm.
the reason I think California has been successful is because California writ large is in a broader population-based payment world, and those are the type of models that I think have been successful at the level of CMS and the type of things they've done. And certainly here in Massachusetts, when we looked at the alternative quality contract, we also demonstrated this. So the notion of sort of moving California to the rest of the world is complicated because the rest of the world turns out not to be California. The delivery system is different. It
Yeah.
takes a long time to build these models and processes. I don't think, people say we should make the American healthcare system like the Canadian system or the British system. And there's certainly things from those systems we can learn. And in many ways, they do better than we do. But I don't think it's as simple as turning a switch and making us look like those other places. The same is true in California. In fact, some of the California things that have been quite successful have had a hard time diffusing outside of California. I think the principle
Right.
of looking at the type of models that have been implemented and how they have done and the learnings from them is much more important than a scorecarding. And I really bristle at the sort of generalizations of looking at a sort of top line result and generalizing. So I think it's important, A, to understand the type of models that have been successful or not. Again, I think the population based payment models, even if you look within bundles, I'll give you an example with BPCIA. I have absolutely no doubt that some of the bundled episode based payment models have saved money. And I think with no deleterious consequences on quality, maybe even improvements. But if you look again at BPCIA, you'll see huge heterogeneity in results across the bundles. So you could either conclude that bundles don't work because on average it hasn't been successful, or you conclude there's certain places, I'll pick ortho, but there's a bunch, there's
Right.
certain places where bundles actually really work well. And so I am um, I am constantly trying to get the policy community and people writ large to understand the nuances of what we've learned from these evaluations, as opposed to take the top line sort of results and conclude we need to go on a different path. And I think in California, the one reason why you've been successful, apart from a lot of hard work, I know Bob Margolis from Health Partners well. I mean, that's not like it just came up overnight. And I don't know a ton about what went on there. You could tell me a lot more. But
Hmm.
these are, Kaiser's the same way, decades long continuing evolution about how these systems work. And my perception of California, and I did live there for a number of years, is it is broadly speaking a population based payment world in ways that much of the rest of the country is not. And I think the evidence from CMMI and the evidence in California and the evidence that we did here from Massachusetts Alternative Quality Contract is that you can be successful in these models, although there are a lot of design issues and details that matter.
And it's sort of funny. I probably should leave this point, but I'm thinking of an analogy. So during the fires in California, just I guess last year, that were so destructive, there was the complaint that the Washington D.C. didn't care as much as it should, and maybe the administration. And some suggested that the distance, the many miles, the geographic distance between DC and California had something to do with the, I guess, lower level of attention than DC gave California than it should. And, I'm wondering if maybe the California success is somehow not as appreciated as it should, also because of the distance involved. I don't know. Um,
I don't know. I mean, a lot of things start in California and diffuse across the country. I won't comment on that. I certainly people, I have lived in California a bunch, but I haven't for years. And it's a big state. It's a state that has a lot of outstanding and prominent people that work there. It is not a state that is unknown. I think it's not so much distance. I think it's just sort of context. By the way, the same Massachusetts, a lot of work on health reform has been modeled off of Massachusetts,
right.
but not every place can be Massachusetts. And so I think, at the end of the day, healthcare is largely local. Um, Again, the delivery system in different places varies. The culture in different places vary. The solutions in different places will likely vary. I think the building of models that will allow organizations to survive. So this is why I think, for example, of a multi-track model, you're not going to be able to build or diffuse California one place or another. In fact, there's a real question of what is the California model. And again, I would argue even within California, there's big differences between different parts of California and different plans within
Agreed.
California that have,
Agreed.
it's not like one California model.
I
I
agree.
think CMS is not going to be able to run an infinite number of models. And I think if they did, it would be a disaster because the models have to work well together. But I do think they can provide a set of models that span the core things that I suspect you like in California, and then allow the local areas and the delivery systems and other organizations plans and there's all these new startup companies with advanced primary care and whatever, adapt to those models. I think the mission of payment is to create a payment landscape that enables people to succeed without, overly, without creating a landscape that works across purposes. And I do think this is exactly where CMS and CMMI are broadly heading, and it
Hmm.
is so complex, it's just not something to expect to be built instantly.
That's
Um,
good.
but I guess the last thing I'll say is, as much as I care about health quality and access and all of those things, the core forces driving healthcare right now, I believe, are financial, and um, that means we will only succeed if the delivery system can deliver care as efficiently as possible. And we will see with the new Alzheimer's drug, for example, all of the sort of blemishes of the American system, which is not designed in many ways for fiscal sustainability. And I think for all the providers, hospitals, physicians, um, a whole slew of other professionals, nurse practitioners, a whole bunch of other physician assistants, med techs, have to think about how we can combine the underlying resources devoted to healthcare in a way that provides access to high quality care for everybody uh, in a fiscally sustainable way. And I think that basic core goal has to transcend uh, a lot of activity now, which I think is exploiting the nooks and crannies of the flaws in the way that we've set up our healthcare system.
So I happen to agree completely that fiscal sustainability, affordability really is the primary driver. I think our trust funds are due to go insolvent in 2024. So, I mean, we clearly have fiscal issues, but I'll push back a little bit maybe. We also have a huge issue in terms of health equity, right? And brought to light for a number of reasons, but dramatically because of the pandemic. And it's a clearly a huge priority for the administration and I think Congress, and appropriately so. So let me ask you about health equity and payment models and your view on how we might address health equity issues basically through payment. Is population payment helpful, necessary, desirable, or not? Can we look to fee for service to get it done? Or do we again find ourselves looking at payment model as being an important element of the armamentarium to mitigate disparities and the like? What do you think?
Well, I mean, I agree. I'm the vice chair of the Connector here in Massachusetts. We put all of our policies now through an equity lens. I think
Hmm.
it has been for a long time. We did work on benefit design, I don't know, 10, 15 years ago, where as healthcare benefits were becoming less generous, there was more out of pocket, focused on the disparity aspects of using a cost sharing strategy to control healthcare spending growth. So while it has certainly taken the fore in public policy, it's been a issue important to me for a long, long time. Um, I think any payment model can be supportive of these goals. There's certainly some reasons why I think it could be helpful in alternative payment models. We did a study again before years ago on impact of alternative payment models on disparities. We actually found here in Massachusetts that the AQC lessened disparities. But again, the devil in all of these things is in the details. It's in how you build the measures, how you implement the various programs you put into place. One thing that is nice about these other types of alternative payment models is they allow you some flexibility to deal with issues related to social determinants of health in ways that might be more difficult in a fee-for-service environment, where you're constantly trying to figure out, is this particular service you want to deliver to this population covered? Whereas in a broader population-based payment model, you don't have to worry that once you cover a new service, its use will spin out of control. It can be used much more strategically by organizations focused on better care, less disparities, things like that. But that doesn't mean that if you change the payment models, we're guaranteed to get what we want. So one of the areas of continual learning, including the quality measurement portion of this,
Hmm.
is going to have to focus around disparities. Again, my general view is the word disparities is important. People use other words for it.
Hmm.
I agree. I think it's really about where the rubber meets the road. What are you actually doing? And that's why, again, at the connector, we use the phrase put things through an equity lens. I'm not sure that's the best phrase. Semantics are hard. But the spirit is to think about things that perhaps weren't always thought about. And I think you can do that. And there's some flexibility in payment models that allows you to do that, but certainly doesn't guarantee that they will happen.
Well. So let me push it one step further. Maybe this is simplistic of me, but it's as follows. Methinks that if you capitate a group for a population, and a portion of that population is the victim of structural or institutional racism, such that their health status is lower than others in the population, that hurts the group. So they're financially incented to think about that issue and maybe address it. So the payment model creates just some opportunity that there will at least be a fleeting thought about the problems that we're talking about. Fee for service, not at all the case. I also think that most of these value-based programs, even now MIPS, which means fee for service to a certain extent, but most of the value-based programs are bolted onto prospective payment. I think of California Pay for Performance, I think of Medicare Advantage STARS program. Which performance measurement programs create the architecture right now for us to add multiple measures to assess how we're doing with disparities and the like? So I have this strong bias, as you can tell, that these value models are a horse that's sitting there ready to be saddled to help deal with health equity issues better than fee for service, and yet another reason for us to move to value. Am I thinking crazy, or is that got some
No,
sense to
I
it?
think it's certainly not crazy. I think what I would say is that is certainly reasonable, but understand that a core component of these value-based models tends to be transferring accountability, which is a euphemism in many ways for risk, to
Hmm.
the providers. And that means there is an underlying incentive in many of these models to deliver less care. And
Right.
so while it is certainly the case that you have more flexibility, you can do a lot more good, you may also worry that some populations may be disadvantaged by organizations that are not incented to give them care. They are incented to keep them away from the delivery system. So it is important that we continue to monitor the actual performance of these things. As I said, here in Massachusetts, for a bunch of reasons, the empirical result was in fact that spending went down, quality was better or the same, and disparities also were reduced. That's what happened here. But that is not a guaranteed outcome. There are a whole range of issues around system design and management that the details matter. And so I think you and I and many people share aspirationally the desire to make the healthcare system better for everybody,
Hmm.
and that includes making sure that all populations have access to high quality care in a bunch of ways. And in doing so, we, I think, have to not assume that we can set up payment this way or that way and will therefore inherently get the result that we want. But we have to continue to monitor. We have to think about that. You mentioned this in how we measure quality, and I'm not a quality measurement person per se, but we need to think about what type of measures might be incorporated. I think there's some folks in California that are working on those types of measures now. California has been a leader in some aspects of quality measurement.
Jeff Fried and IHA is at work on it right now.
Yeah, exactly. So I do think, and I know Jeff, and I think they're doing very important work. Um, it's that we didn't get into where we are now particularly quickly, and we're not going to have the system change quickly. In fact, I there's a lot of people that want us to move bolder and faster, and I certainly understand that, and I'm sympathetic to it. My concern, of course, is we have to move in a way that doesn't create large disruptions in the system. And so um, I tend to be a bit of a nibbler in some ways about how we should change things. I think we
Hmm.
need to build models. We need to have people to have sort of on ramps to alternative payment models. We need to understand that uh, we can't have dramatic changes in the revenue that organizations are getting. Um, because you you can't just assume that if you cut revenues by 20%, the delivery system will just be exactly the same. Everyone just get 20% less. There's a lot that can be done that can be harmful, and we need to maintain, as we go through this transition, access to care in the interim. And so it's a bit of a slow, hopefully somewhat deliberative, and certainly hopefully flexible process as we do that. And I think it's a good thing that the health equity disparities issues has been put on the table and is receiving the attention it is receiving. And hopefully we will be able to move the system in the right direction. But it really depends on evaluations of very specific policies. And certainly COVID illustrated how
Hmm.
important these things are.
Hmm. Well, I, for one, am very, very glad we have you and MEDPAC helping us work through these issues. I feel in good hands, frankly. And with that, I should thank you and wrap up. I think, Michael, I've taken more of your time than we expected because it's been so much fun talking with you, and I think we should do it again soon. So,
So, first of all, thank
uh
you for the opportunity to talk to you. I always enjoy your perspectives, and thank you for the opportunity to talk to your audience. They are really, I think, the bedrock of how we're going to transform the system. I'm sorry we went long. It's surely because my answers were not capitated, but nevertheless, I would love to talk more, and so feel free to reach out again.
yeah, but your comments get 4 stars across the board, so it's well worth it.
There,
Thank
there
you,
you
Michael.
go. There you go. Thank you, Don. Thank you,
Okay,
Don.
okay, my friend.
That's great. All
Stay
right.
well. All right. As you may have observed, our annual conference this year will now be held in person, December 9th through December 11th at the Marriott Marquis San Diego Marina. Please save the date and be sure to register. It will be, to say the least, an extraordinarily welcome and refreshing chance to see each other in person once again. In the meantime, stay safe and be well.
Thanks for listening to APG on American Healthcare with your host, APG President and CEO Don Crane. For more information about APG and transcripts of this show, visit the APG website at apg.org.